Hey folks, it's Arjun again, here with the final segment of endocrinology, endocrine pharmacology. After this section, you will have the tools to become an endocrine legend, so let's finish this guy out strong. As with our other videos, we here at First Aid like to ask questions, and it's not because we like to hear ourselves talk. Even though you could wait the 1 or 2 seconds it takes to hear the answer, I strongly encourage you to try to come up with the answers on your own. It'll help keep you engaged and give you sort of an idea of how well you actually remember some of this stuff. So without further ado, let's start off with the drugs for diabetes. So I'll let you in on a little secret. Most of endocrine pharmacology is actually pretty easy, at least what you need to know for step one. Basically, the solution to every other endocrine disorder is either cut the tumor out or give the patient supplementary hormones. The one exception to this is the drug for diabetes mellitus, which actually takes up the majority of the pharm section. Let's start off with a review of management of each type of diabetes before we dive into the drugs. Type 1 is definitely the most straightforward, so you tell me, what's the only way to manage type 1 diabetes? So, since type 1 is an autoimmune gland destruction, just like any other gland destruction, it requires hormone replacement. It's additionally helpful for these patients to eat low-carb diets to control their insulin spikes during the mealtimes. With type 2 diabetes and gestational diabetes, which is basically just fetus-induced type 2 diabetes, the first step is always to attempt diet and exercise before pharmacotherapy. Because obesity is such a predisposing factor in type 2 diabetes, the goal of lifestyle change is weight loss. Now this is important because it does come up on the test, and a lot of people get confused because they hear about low carb and low glycemic index foods that are supposed to help, but really, the only thing that's proven to be really beneficial is calorie restriction and some time at the gym in order to shed the pounds. If you're pregnant, you gotta be a little bit more careful about that because any crazy calorie cutting or extreme exercises could affect the baby. If a patient's tried diet and exercise and is still in the danger zone, it's time to pull out the drugs. Metformin is the unquestionable champion for type 2 diabetes. It's the safest, one of the most effective, and you don't have to prick yourself with a needle to take it. If you've got to add another drug after that, you've got to weigh the costs and benefits of the other treatments, which can include oral hypoglycemics or insulin. With gestational diabetes, if diet and exercise don't work, most people would actually just jump straight to the insulin. Well, what about the other drugs, specifically the oral hypoglycemics that the type 2 patients love so much? To be honest, there's no really good reason not to use them. There just isn't as much clinical evidence to support their use. As you probably can imagine, clinical trials on pregnant women tend to be more sparse because nobody wants dead babies on their hands. You know, in case their drug ends up being the new thalidomide. Anyway, the correct answer for step one is not metformin. For gestational diabetes, you're going to want to use insulin as the first-line pharmacotherapy. So, speaking of insulin, it can be used for essentially every different kind of diabetes, and it's conceptually the most straightforward to begin with. Y'all know what insulin does, so I'm not going to bore you with the details. Just remember that the pharmacologically relevant actions are that it decreases blood glucose, inhibits ketogenesis, and moves serum potassium into the cells. Remember the diagnostic criteria for diabetes? Broadly speaking, diabetes can be diagnosed if you're symptomatic, have impaired fasting glucose, or if you can't adequately bring down your glucose level within 2 hours after a meal, known as impaired glucose tolerance. Now, depending on the patient, these two problems can actually occur in different ratios. For example, type 1 diabetics tend to have a more horrible glucose tolerance. Now, what does this all have to do with insulin? Well, there used to be only one kind of insulin called regular insulin. Peaks in about 2 hours, lasts for about 9. But since then, different formulations have been made to separately deal with the issues that the different diabetics face. Fast-acting formulations like aspart, lispro, and glulicine are made for individuals with poor glucose tolerance. They peak within an hour to help quickly bring down a patient's glucose postprandially, or after a meal. Insulin detamir, on the other hand, is specifically formulated to last the whole day for patients who have trouble keeping down their fasting blood sugar. Insulin glargine is kind of an improvement on this concept as it sustains a plateau of efficacy for a more stable basal insulin level. Then you have NPH insulin, which, contrary to popular belief, doesn't stand for Neil Patrick Harris. It's neutral protamine hagedorn, which, I kid you not, is made by mixing insulin with an extract of fish semen. Yuck. Anyway, it's mixed with other insulins now to make it more effective, but what you need to remember for this test is that it's neither a long-acting nor a short-acting insulin. So what happened to old regular insulin? Believe it or not, it actually didn't fall by the wayside. First of all, it's pretty cheap, so we still use it. Second of all, it's the most titratable insulin we have. Most of these are actually best suited for subcutaneous use, but regular insulin is the insulin of choice for IV applications in the hospital. such as DKA, hyperglycemic hyperosmolar state, and hyperkalemia. So, what's the most important side effect of insulin? This is actually a really important one. You can very easily become hypoglycemic, especially with the rapid-acting formulations. Now, I don't know if any of you all have diabetes, but calculating insulin requirements can be pretty hard. And if you happen to eat a little bit less or exercise a little bit more than you are accounting for, you can easily throw yourself into hypoglycemia. Exogenous insulin is actually the most common reason for patients to present with hypoglycemia, so before you jump to insulinoma in your vignette, try to figure out whether or not the patient's diabetic. Another side effect that at first aid doesn't mention, but that I find worthwhile to bring up, is weight gain. Which makes sense, right? Insulin's an anabolic hormone, so taking more of it will tend to pack on the pounds. Now in type 1 diabetics, this is really a so what sort of a question, unless they're body-conscious adolescents. But this is an important complication in type 2 diabetics, where obesity is actually a major contributor to the overall problem. This actually helps make a great selling point for the next drug I'm going to talk about, metformin, which is the unequivocal best drug for type 2 diabetics. So metformin is the only drug of the biguanide class, and it primarily works by suppressing hepatic gluconeogenesis, and to a lesser extent, increasing hepatic glycolysis, which shunts it towards the glycogen storage pathway. This keeps insulin out of the blood and away from other cells, but metformin additionally increases insulin sensitivity in the other cells, allowing for greater glucose uptake and a greater decrease of blood sugar. So why is metformin the best? The two easiest answers are that it's the most effective and the safest oral drug for type 2 diabetics. The most common side effect is gastrointestinal upset, which is usually pretty transient, and it does not cause hypoglycemia, unlike insulin. The other big deal is the fact that metformin, unlike most of the other diabetic drugs, actually causes weight loss as opposed to weight gain. Kind of makes sense if you think about it. Metformin keeps glucose in the liver and keeps it away from the adipocytes that'll store it as fat. The only major con of metformin is that it can cause lactic acidosis, because of how it alters liver metabolism. So think through this. Why could metformin cause lactic acidosis? It's all about the Cori cycle. See, the muscles normally send lactate over to the liver to get converted back to glucose, but guess what metformin inhibits? Bam! So, lactic acid will tend towards the high side, which actually the kidney is normally pretty good at dealing with. But if a patient has renal failure, this can actually lead to fatal lactic acidosis. So, this is a contraindication that you really need to know about. Patients with renal failure cannot get metformin. The other two diabetic drugs that are reasonably high yield are the sulfonylureas and the thiazolidine diones. Sulfonylureas are the ones that all end in "ide," but so does just about every drug. Just spend some time memorizing it, the list is in first aid. The other category is the glitazones, which are more masochistically known as the thiazolidine diones. At least they all end in glitazone, so you can recognize them when you see them. The sulfonylureas act by increasing endogenous insulin secretion in a physiologically very interesting way. They shut down the ATP-sensitive potassium channels in the signal cascade that leads to insulin release. If you don't remember that cascade, check out my video at the beginning of Endocrine Physiology. I have a pretty cool animation that breaks it down pretty well. The glitazones, on the other hand, act by increasing peripheral insulin sensitivity. They do so via the PPAR gamma receptor, and you don't need to know what it is or how it works, just memorize the buzzword. Both of these drugs are pretty effective, which is why you need to know about them. Not as effective as either insulin or metformin, but as you can probably guess, many diabetics need their own personalized drug cocktail to manage their blood sugar. Sulfonylureas are probably the most effective adjuncts to metformin if one oral agent isn't doing it. But the main draw of the glitazone class is that they're the best oral agents in patients with chronic kidney disease. Remember, with metformin, you run the risk of fatal lactic acidosis in renal patients, and, as it turns out, since the sulfonylureas are renally excreted, they can actually accumulate in renal patients and get a dangerously increased side effect profile. So, speaking of side effects, you should be pretty familiar with the side effect profile of both of these drugs, and for the most part, they're pretty logical. So, which of these two would you guess is most likely to cause hypoglycemia? It's the sulfonylurea class because it's literally increasing insulin. It can cause your blood sugar to drop just like exogenous insulin, which, it's worth restating, is most likely in patients with renal failure because the drug can't properly be excreted. The glitazones are less likely to cause hypoglycemia since they only increase peripheral insulin sensitivity, kind of like metformin. Both of these can actually cause mild weight gain. Sulfonylurea is in a manner similar to insulin, and glitazones, because unlike metformin, they allow cells to suck up more glucose without limiting their supply from the hepatic glycogen stores. The glitazones additionally cause fluid retention that leads to edema pretty regularly. Some less intuitive side effects include a disulfiram-like effect for the sulfonylureas, in which patients on first-gen sulfonylureas, that's the ones that don't start with GLI, get violently sick upon drinking alcohol. There are also some incredibly rare but very serious side effects of the glitazones, including liver toxicity, heart failure, and bone loss that leads to an increased risk of fractures. For your own clinical knowledge, it's probably just being overcautious because of some of the older glitazones, but people are prescribed the newer glitazones all the time without problems. But, the correct step one answer is that these are all legitimate risks of glitazone use. Finally, a word about the sulfonylureas. The concept of increasing endogenous synthesis of insulin rather than having to stick yourself with a needle is kind of a cool one. But obviously there's one major limitation. You have to have a working pancreas in order for that to work. Now, the type 1 diabetics aren't going to be using these drugs anyway. They really just take insulin and leave it at that. But remember, many type 2 diabetics lose their beta cell function later in the disease process. So sulfonylureas may not be effective in every type 2 diabetic. Just remember that. And the list goes on and on and on. If you're at the point where you'd rather do a rectal exam on an angry alpaca than learn about any more diabetes drugs, well, I got good news for you. The last 4 drugs, insulin, metformin, sulfonylureas, and glitazones, those cover about 90% of the diabetes drug questions you'll see on step 1. You may see 1 or 2 on all the rest of the other drugs combined, but I'd rather you kept your sanity and skipped ahead in the video than killed it over these points. For those of you with the fortitude to continue though, let's muscle through it. Meglitinides, the drugs that end in glinide, are easy ones to start with because they work just like sulfonylureas. Remind me how that goes again? These drugs also inhibit the ATP-sensitive potassium channels on the beta cells, causing increased endogenous synthesis of insulin. As such, the side effects are much the same, but the really nice thing about these things is that they're not excreted by the kidneys, so they're safer for renal patients than the sulfonylureas. They're pretty new, so there's not as much evidence as to their efficacy, but I'm thinking they're a pretty strong candidate in the diabetes game. GLP-1 analogs and the DPP-4 inhibitors both act on the pancreas to increase insulin and decrease glucagon production. Weirdly enough, they don't cause a ton of hypoglycemia. GLP-1 agonists can cause the symptoms of GI upset and infrequently pancreatitis, whereas the DPP-4 inhibitors cause predisposition to mild urinary and respiratory tract infections. The amylin analogs, of which pramlintide is the only one you have to remember, works both on the pancreas to decrease glucagon synthesis and on the pylorus to decrease gastric emptying. The purpose of this is ostensibly to slow down the glucose spike that typically follows a meal and give the body some time to adjust. Hypoglycemia is a significant adverse effect of this medication, and because the drug affects motility, nausea and diarrhea are also not uncommon. One interesting point about this medication, because the slowed gastric motility helps blunt the glucose spike, it can actually help type 1 diabetics as well, because of their severely impaired oral glucose tolerance. Alpha-glucosidase inhibitors are the ones that make the most mechanistic sense to me. They just block the digestion of carbohydrates at the brush border of the intestines, which means they don't become simple sugars, which means they don't get absorbed. The consequences are exactly what you'd expect from a bunch of undigested carbs running through your bowels. Just like in lactose intolerance, the undigested carbohydrates get chewed up by bacteria in the ileum and the colon, which cause gas, diarrhea, bloating, and general unpleasantness. The final drug class, the SGLT2 inhibitors, is the only one that doesn't act on the GI tract. It actually acts on the kidneys to inhibit the resorption of glucose from the urine and just, let it all out. Which actually sounds like a pretty dumb idea, to be perfectly honest. Think about things like HHS and DKA and realize that a lot of the problems actually come from the fact that you're offloading a ton of sugar into your urine, dragging water behind it, and potassium via osmotic drag and contraction hypokalemia. So, just like DKA and HHS, dehydration and hypokalemia are significant and potentially dangerous side effects. There's also a slightly grosser side effect inducing glucosuria. Bacteria and fungi love sugar, even if it's mixed with pee, and they will go to town on your sweet, sweet urine. And that's it for the diabetes drugs. For those of you still with us, I think it's time to reward you with a flash quiz. The question is, for which types of diabetes would insulin be considered a first-line pharmacotherapy? And the answer is, insulin is first-line drug for type 1 diabetes and gestational diabetes. Remember, type 2 diabetes also makes use of insulin, but makes more use of the oral hypoglycemic agents, especially metformin.